2016 version of this guideline. So just 7 years. But one of the great pleasures of working on this guideline with such a multidisciplinary group, many of which are in the room, one of the great pleasures was just discovering in areas that perhaps I wouldn't be busy reading the primary research, but just discovering how much the evidence has moved on, perhaps particularly so in the rehabilitation field. And we'll hear from Louise particularly later about just how much evidence-based practice is moving on in stroke, and it's great to see that happening, and it's great to see that we've now got the evidence at our disposal to help our patients all the more. So before we embark on the main content of the meeting, a couple of early thanks. Firstly, of course, to those who funded the guideline. We wouldn't have been able to embark on this project without the generous and unquestioning and no strings attached support from the Stroke Association, from Johnson & Johnson, from NIMAST in Northern Ireland, and from the Welsh Stroke Group. And so we are immensely grateful to them for actually bringing us to this point here now. And also to those who've endorsed the guideline, of course, for clinical use, the Royal College of Physicians of London, SIGN, of course, in Scotland, and the Royal College of Physicians in Ireland. And of course, there's a huge number of contributing organisations. The Guideline Development Group has had broad representation from all these professional bodies and interested parties. And of course, again, we come to this point today through an enormous collective effort from several hundred people in contributing in various ways. So my grateful thanks and acknowledgement go to my colleagues, the editors, to all those, again, many of you in this room who are members of the Guideline Development Group, to those who did the heavy lifting as topic group leads and reviewers of evidence, and to the guideline staff who are still, even at this stage, busy making sure everything's running smoothly for this meeting, and to my colleagues in the SNAP team as well, who are again with us this afternoon. And you'll hear from them a little later from our patient voice representatives. And when they present to you one of the aspects of this guideline that we're particularly proud of, which is the patient and carer, or as we call it now, the plain language summary. And you've got a copy of that in your tote bag to go and brandish, and you can download and print more of those from the resources section of the website. Just a couple of issues for practicality, especially for those of you who are on Zoom. If you want to ask a question to our Q&A section about implementation later on, then please use the Q&A function on Zoom. I think if you try and use the chat function, it'll either not work or we won't be looking at the chat function for questions, so you can have all sorts of other parallel conversations about other stuff while the meetings are going on. But if you want to submit a question, you'll need to use the Q&A function. And of course, we'll be recording this so that it can go on the resources section of the website and be used as a teaching resource anywhere and wherever you like in disseminating the guidelines. And that's one of the key aspects of what we're trying to do this afternoon. Yes, we're going to introduce you to the major changes, but then we're going to focus and talk about dissemination and about how to get this new guidance into clinical practice on a daily basis. And that's the sort of exciting and most important part of any guideline production, is getting clinical practice change. So we're going to kick things off then with an introduction to an introduction. I'm going to invite Deb just to come up and tell you who she is, if none of you, if you don't know, and she's then going to introduce Professor Sir Stephen Powis, who's got a few words to say to kick us off. Thank you very much, Deb.
Good afternoon, everybody. I'm Deb Lowe. I'm the National Clinical Director for Stroke Medicine with NHS England, and also a stroke doctor on the Wirral, just near to Liverpool. Just to echo Martin's comments, thank you so much to all the brilliant people in this room and virtually who've worked tirelessly over the last 12 months and more on the 6th edition of these guidelines. And it's all been under the expert leadership of Professor Martin James, and it's been a real privilege to be even a small part of the production. I can really vividly remember in 2000 when I was a research registrar at Fazakerley Hospital in Liverpool, working under the amazing Anil Sharma, who was my Yoda. We all need someone, don't we, that we always look up to and model ourselves on, and he was mine. And he'd opened one of the first stroke units in the country because they didn't exist, and stroke patients would be left languishing on general medical wards. And I remember in 2000, the first guideline landing on my desk and feeling super excited. It was hard copy, it was in colour print, and it was actually white paper, not the new brown paper that we get with anything printed in the NHS. And I was so excited by it. It was a real tome, and I remember reading it in bed at night, and my partner at the time thought I was a really Billy No Mate's dull person, and maybe that's true, but reading those guidelines, I decided I was going to go onto the stroke unit, speak to all the therapy staff and nursing staff, and do a little gap analysis and work out what we were delivering and what we weren't. And every year since, with the iterations and different editions we've had, I've tried to do that in the services that I've worked in. I think it's a really good benchmark, and hopefully this 6th edition will be an opportunity for us to just take a breath and look at what we are delivering across our stroke pathway and how we can do better for our stroke survivors and their families. And I think ever since the last guidelines in 2016, we have come so far, haven't we, around reperfusion therapies, pre-hospital medicine, certainly looking at the idea that you had daily ward rounds and weekend access to therapy in 2016 even would have been just a real pipe dream. We've got advanced imaging, artificial intelligence, and certainly it feels like all of the stars are aligning at the moment between the policy direction, political will and power to make a difference for our stroke patients and our stroke pathway, commissioning with our new integrated care systems in England, and when I think a clinical consensus, an academic consensus and voice comes together, then things really do align, and we've got a real opportunity to make a difference. So the stage is set, I think, for the spotlight to be on stroke and to stay on stroke. And in England, we're in a new home or theatre because we're moving into the new major conditions strategy. And I think that will give us a real opportunity for our voices, a clinical community, to be amplified. Our scripts are written, so we've got our National Stroke Service Model, we've got our Integrated Community Stroke Service Model, we've got the GIRF 29 national recommendations for service delivery. We've got our amazing, recently recommissioned national audit within SNAP. And I think there's a real opportunity now to decide what our joined narrative and voices to really make sure that stroke, there's a parity of esteem across other long-term conditions. And I think really framing things around prevention being our opening act is what we should be doing. So prevention of stroke, primary stroke, prevention of recurrent stroke, prevention of disability, whether that's physical, cognitive, psychological, emotional, and prevention of personal and societal loss that we see every single day in our nations as a result of stroke disease. But we mustn't forget that the most important asset that we've got in this stage, in this production, is our cast and our crew. And that's our incredible multidisciplinary workforce in health and social care, the incredible support we get from our voluntary sector, our stroke networks that are obviously being established over the last 3 years within England. They're up and running or in the process of. Shakeel's doing an amazing job in Wales with setting up networks. And we need to understand the currency that we've got as well when we're trying to influence decision makers and our audience. And our audience and our most important critics, but also our supporters, are our stroke survivors and their families. So when we're trying to influence things, we must make sure that we are putting our stroke survivors and patients and their families at the centre of everything that we do and the narrative that we're creating. And in the virtual royal box in our theatre today is, I think, the most influential cheerleader and advocate for stroke care that I've come across in my role, and that's Professor Sir Steve Powis, who is the Medical Director for NHS England. and is the executive sponsor and senior responsible officer for the National Stroke Programme. Unfortunately, he couldn't be here today, but he's been at another very important meeting to try and make sure that stroke and other major long-term conditions stay with the same priority that they've had over the last few years. And I know that Steve is sorry he couldn't be here, but wanted to just send a message of support and commitment to you all. Thank you.
Stroke is a national priority, and as the NHS England Executive Lead for the National Stroke Programme, it's also a personal priority for me. I don't have to tell anyone here today that stroke is a preventable condition, yet it's the fourth single leading cause of death in the UK and the single largest cause of complex disability. The recent NHS priorities and operational planning guidance emphasises the need to continue to make progress on delivering our key ambitions in the NHS long-term plan. Now for stroke, this means a focus on prevention, reducing smoking rates, lowering lipid levels, optimising blood pressure control, and identifying and, where appropriate, anticoagulating individuals with atrial fibrillation. It includes improving the use of thrombolysis and expanding the provision of mechanical thrombectomy to significantly reduce the severity of disability. And it means the further development of higher intensity care models for stroke rehabilitation to support improved outcomes for patients. The 2023 National Clinical Guideline for Stroke for the UK and Ireland highlights the evidence that underpins these ambitions, providing a unique opportunity to drive improvements in the delivery of stroke care as prioritised in NHS England policy. It provides clear evidence-based support for clinical teams to deliver improvements in stroke care and better outcomes for people with stroke and transient ischemic attacks. With respect to hospital-based care, the guideline includes revised recommendations relating to extended time windows for eligibility for thrombolysis, with guidelines for treatment beyond 4.5 hours post-stroke. This aligns with NHS England's target for increasing the proportion of patients accessing thrombolysis to 20%. There's also evidence-based guidance for the provision of thrombectomy between 6 to 24 hours post-stroke and guidance to ensure that patients eligible for thrombolysis and thrombectomy can benefit from both. Once again, this aligns with the NHS target for increasing the percentage of patients accessing thrombectomy to 10%. Other key highlights include evidence-based recommendations for the delivery of community stroke rehabilitation services, which align with the National Integrated Community Stroke Service model published by NHS England in 2022, and an expanded chapter on rehabilitation and recovery, reflecting a substantial evidence base and again underpinning NHS England's stroke programme's priorities relating to the improvement of access to high-intensity and needs-based stroke rehabilitation services. These are vital for the recovery from stroke and for improved quality of life. Now, I'm really sorry that I'm unable to be with you today, but I'm absent for a really good reason. I'm attending a roundtable hosted by the Secretary of State for Health and Social Care on the UK government's recently announced Major Conditions Strategy. This strategy aims to set out a clear and strong integrated and person-centred approach for 6 major conditions, recognising that these are conditions that often occur together. Cardiovascular disease, and specifically and explicitly stroke, is one of the 6 conditions. The work to develop the strategy is still at an early stage, but I believe it will provide a huge opportunity to build on the NHS long-term plan to turbocharge improvements in stroke prevention and care. I know that's a view shared by our partners in this ambition, including the Stroke Association. So, with apologies once again for not being with you in person, I want to finish by thanking all of you for the tremendous support you provide in driving improvements for stroke survivors and for those at risk of stroke. And to urge you all to use the opportunities provided by this revised guideline, by our ongoing long-term plan programme, and by the new major condition strategy to go further, faster.
And our thanks to Sir Steve for his words and his interest, and as Deb says, his commitment to improving the lot of people with stroke and reducing disability from stroke. So This next section really is going to be a series of 4 very quick summaries of where the evidence has changed, corresponding pretty closely to the 4 principal chapters in the updated guideline. And so, without further ado, I'll step aside and invite Rebecca Fisher to come and talk us through Chapter 2 and what's new in the organisation of stroke services.
Thank you, Martin, and good afternoon, everyone, and thank you for coming here today and tuning in on Zoom. So, as Martin said, I'm going to focus on the organisation of services chapter. And I really want to take the opportunity, picking up from some of the words from Sir Steve Powis around the fact that the launch of these guidelines reflects a substantial evidence base for stroke rehabilitation. Louise is going to focus her section, as reflected by the chapter, on complex intervention and therapy provision. But here I want to talk about the organisation of service delivery. I'll focus on community-based services, also mention inpatient rehabilitation. I won't be covering, but it is in the guidelines, recommendations around hyperacute and acute stroke care. Ajay will cover some of those themes in the next presentation. Before I go any further, I really do want to thank the topic leads in particular, but also topic group members for the amazing work. Martin mentioned it earlier, but really fantastic. We couldn't have done it without you. And personally, I've really got to know Cara Lewis, Sue Pownell and Nicole Walmsley. We went through some great times together and I really want to thank you. So again, picking up on some of the words from Steve, I think there is a real opportunity at the moment, particularly with the launch of the guidelines, to reflect and emphasise on the fact that we have in NHS England national policy that the guidelines underpin, and we need to use the opportunity both with the policy and with the guidelines to use those to drive improvements in the care that stroke survivors receive. In preparing for this presentation, I was also thinking about SNAP and the role that Louise and I have been doing over the last few years, and the only second post-acute organisational audit where we mapped the provision of post-acute care and community-based care. And again, the key performance indicators that we used in that activity are underpinned by the recommendations that are now summarised in the launch of this guideline. So we need to continue to use those key performance indicators to inform service provision and quality improvement going forward. So in terms of what's new, just to go in a little bit more detail on the section around community-based stroke care. What's new is that there's more detail around the provision of early supported discharge and community stroke rehabilitation. So you'll see in the table we have listed the key disciplines. We've also listed disciplines and treatments that patients need timely access to. There are also, for the first time, staffing recommendations. And I think it's important here that we don't get too hung up on the absolute figures of those staffing recommendations. Those are there as a starting point to be used in conjunction with an understanding of the local context and local data to inform more detailed service specifications. We've also tightened up on the definitions around early supported discharge and community stroke rehabilitation. Certainly the movement of travel within England is that we consider early supported discharge as a specific intervention that facilitates transfer of care from hospital to home and provides time-limited, intense rehabilitation when patients first get home. But that can be provided by a wider team that also provides longer-term needs-based community stroke rehabilitation. I couldn't not take the opportunity whilst I was talking about this to reflect on personally on the body of evidence that underpins those recommendations, for which I am immensely proud. It started with Peter Langhorne and the systematic review with early supported discharge. I then had the pleasure and the privilege to work for many years with Professor Marion Walker, where we built on the meta-analysis and the understanding of those trials to run a body of work that looked at facilitating evidence-based practice in the community. This culminated with the fantastic work from a talented team at the University of Nottingham, using qualitative and quantitative research to show really for the first time that there was a systematic and statistical significant relationship between service characteristics and outcomes, showing that it does matter what the model of care is that's provided in the community, and that we do need services to adopt core components in order to deliver evidence-based and effective care. I also wanted to briefly cover the section on inpatient care. So there are revised staffing levels for hyperacute and acute and stroke rehabilitation. Again, these highlight the importance of a multidisciplinary team. They've been increased to take into account 7-day working. They're for registered staff, and we make the point that it's important that alongside registered staff, there are support workers and rehabilitation assistants that are supported by those registered staff. Again, I want to emphasise that whilst it's important that we've got staffing level information, critically again, both for inpatient rehabilitation and community rehabilitation, we also need to think about how those staff work together as a multidisciplinary team and also interdisciplinarily, if that's even a word, with the rehab assistants and support workers that are there. I think that's really important, and that staff get the appropriate training that they need and appropriate leadership. So we're here at this time celebrating the fact that we've collaborated across nations, something that Deb mentioned and Martin have mentioned. I think that's a fantastic achievement. So we in NHS England have the Integrated Community Stroke Service model, and I'm particularly proud to be part of the Squire initiative that is driving improvement in stroke rehabilitation. It's also fantastic to see rehabilitation mentioned in the other policy documents, and we really need to work together with this whole stroke care pathway approach to drive the provision of and improve the provision of care for stroke survivors. So in summary, I've covered recommendations for the organisation of stroke services, which represent a substantial evidence base for stroke rehabilitation. I urge you all to use these guidelines with policy to support quality improvement and service transformation. Build on the staffing levels with your own understanding of the context and local narrative and local data, using the support of support workers and rehabilitation assistants. We really need to make sure that we maintain stroke care and stroke rehabilitation in particular as national priorities in order to give stroke survivors the evidence base they deserve. Thank you. Oh, and I forgot, but I hand you over to Dr. Ajay Bhalla. Ajay.
No, thanks, thanks, Rebecca. So I'm going to give you a quick tour of what's new in acute stroke care. And like Rebecca, I wanted to really thank the topic group leads and the members, in particular Phil White, Anthony Pereira, Will Whiteley, and Adrian Parry-Jones. So the key headlines I'm going to really summarise today around thrombolysis, thrombectomy, and intracerebral hemorrhage. So if we look at thrombolysis, are there any alternatives to alteplase? Well, tenecteplase is essentially a genetically modified variant of alteplase. It's got high fibrin specificity, it has a longer plasma half-life, you can give it as a bolus rather than an infusion. And there have been several primary efficacy studies comparing tenecteplase and alteplase with varying dosages. The last two published randomized controlled trials were non-inferiority by design, but demonstrated equivalence compared to alteplase. And these were the ACT study and TRACE-2. And if we just focused on Act 2, which was the largest, had the more broad inclusion, you can see from this slide here that essentially tenecteplase had comparable efficacy and safety when given within 4.5 hours at a dose of 0.25 milligrams per kilogram compared to alteplase. And so this information has been embedded within the recommendation, stipulating that if treatment will be started within 4.5 hours of thrombolysis, one can consider thrombolysis either with alteplase or tenecteplase. But there are some implications. This can be given as a bolus, therefore has the potential to reduce hospital treatment times and also potentially reduce the amount of resource required in emergency care settings. Lots of unanswered questions within subgroups, and there's a plethora of randomised controlled trials that are underway attempting to lend support to these questions. And then I guess the biggest challenge is going to be around implementation, given the thrombolysis shortage worldwide and certainly across Europe. And therefore, European regulators and pharmaceutical industries will perhaps need to provide a very swift response in order to improve the supply thrombolysis, as well as extending the label for usage in acute ischemic stroke. But in order to improve the proportion of patients who will be eligible for thrombolysis, what about different subgroups? What about those patients who have a stroke with an unknown time of onset or with wake-up stroke? And certainly since the last publication in 2016, we've seen a paradigm shift in a way from a time window to more of a tissue clock. And this slide shows essentially the wake-up study. And there was essentially, during this study, it was found that patients who were treated with autoplays, who had a particular MRI signature profile image indicative of 4.5 hours from symptom recognition, was associated with good outcomes at 90 days. And there have been a number of different thrombolysis trials examining the effects during the extended time window, including wake-up stroke. And these trials included an imaging paradigm consisting of essentially target mismatch using CT or MR perfusion with very select stipulated criteria, as illustrated here and exemplified by the Extend study. And if you look at the individual patient data meta-analysis using this particular criteria, you can see from the top panel that usage of autoplays was associated with excellent outcome if you had evidence of perfusion mismatch, with a very striking odds ratio of above 2, compared to the lower panel, where there was no real significant difference in patients with no perfusion mismatch. So just triangulating all that, what does the guideline say? Well, essentially, if you were last known well beyond 4.5 hours, thrombolysis with autoplay should be considered. If it can be commenced between 4.5 and 9 hours, or within 9 hours of midpoints of sleep, and if you have evidence of potential salvable brain tissue on advanced imaging, and this should be really considered irrespective of whether you have large vessel occlusion or require mechanical thrombectomy. So let's turn our attention to thrombectomy. And essentially, I would say since the 2016 guidance has been quite considerable advancement in thrombectomy. I guess with regards to extending the therapeutic time window beyond 6 hours, using advanced imaging for patient selection, and also to look at thrombectomy in a number of different subgroups. And so there have been a plethora of primary efficacy studies in the extended time window with very subtle variations and differences. So you've got trials with employing complex imaging with MR and CT perfusion with automated software. And there have been 2 trials involving the anterior circulation, which have been significant, which I'm sure you know about, Dawn and Diffuse. And then you've got you've got studies with less complex imaging, where there have been 2 recently published randomized controlled trials, literally hot off the press, which looked at the effects of thrombectomy beyond 6 hours up until 24 hours, in particular looking at large ischemic core with aspect score between 3 and 5. And these patients normally would not have been eligible for thrombectomy studies. And this includes SELECT2 and angle aspect, and you've got impressive sort of numbers needed to treat in a late window of 8 and 6 respectively. But I think the caveat with these two trials is that although you are, in a way, enhancing the proportion of patients who will be treated in the late time window, the proportion of patients with a favourable outcome will be far less than if you're treated really quickly. And just note, the median modified Rankin score in these two trials was actually only 4. And of course, you've got Mr. Clean Late. We're still waiting for this to be published, and that's looking at collateral scoring with multi-phase CT. And this may be perhaps a more pragmatic image-based criterion to base further treatments. And then finally, you've got posterior circulatory stroke, and you've got 2 recently published randomized controlled trials. If you have a favourable imaging profile, 2 studies were Attention and Bioch, and you can see the numbers needed to treat to achieve a good outcome. That's a modified Rankin score, on this occasion between 0 and 3, resulting in 4 and 4.5, respectively. So, putting all that together, which is a task in itself, the first recommendation is that patients who are treated with mechanical thrombectomy should also receive prior thrombolysis unless contraindicated, irrespective of whether they present to an acute stroke centre or a thrombectomy centre. And there's acknowledgement here that we should adhere to these time-critical treatments. The second recommendation is really just emphasising what was written in the 2016 publication. So, delivery of mechanical thrombectomy as rapidly as possible with or without IV thrombolysis, unless contraindicated in patients who were previously independent. And then we've emphasised another recommendation, really endorsing the use of thrombectomy in patients in the extended time window, including wake-up stroke, in patients with no previous disability. That's patients with a modified Rankin score of 0 to 1, as reflected in the trials, and also dependent on whether you have a favourable imaging profile depending on your time window. So if you're treated between 6 and 12 hours, an aspect score 3 or more may be sufficient, and this is replicated in the 12 to 24 hours, but with the caveat that you probably do need and require advanced imaging to delineate whether there is adequate perfusion mismatch. And we've mentioned the criteria of 15 mils here, which is in kilter with the Diffuse 3 study. And then the final recommendation is endorsing the use of mechanical thrombectomy in patients with posterior circulatory stroke within the first 12 hours in patients with a measurable neurological deficit, but to apply caution in those patients over the age of 80 and beyond 12 to 24 hours. So what does this mean? Sort of nationally, this is data taken from SNAP over the last several years. You can see from the graph here that the rates are growing, but the growth and the trajectory are still slow. And if you look at the turn of the year, the current rate was just over 3.5%. But I hope, with new evidence coming about, this should provide a really powerful substrate to improve the trajectory in the next year. So the final point I want to talk about is intracerebral hemorrhage. And I think a key narrative from this particular guideline is that it really does emphasise that patients with this condition should have rapid access to hyperacute stroke units for specialist assessment and monitoring, in particular monitoring of hematoma progression, which we know is very common. It can occur very early after stroke, and it can extend even up to 24 hours in patients taking direct oral anticoagulants. And therefore, hemostatic agents play a really important role in potentially modifying its volume. So what's been recommended? Well, urgent anticoagulant reversal is fairly obvious. For patients taking direct thrombin inhibitors, the unpronounceable idarucizumab, got that right, should be considered. 4-factor PCC should also be used in patients taking factor 10A inhibitors, and the novel antidote to anticoagulation, andexanet alpha, should only be considered as part of a trial. What about blood pressure lowering? And there's no real easy answer to this, and I think there's been some renewed, in a way, uncertainty. And this reflects, I think, the complexity of treatments for this particular condition. So here we've got the meta-analysis of a number of randomized controlled trials testing various treatment strategies in blood pressure reduction within 7 days, which showed a modest effect at reducing hematomal expansion. But this didn't really translate into improved functional outcome at 90 days. But you've got some secondary analysis from observational data from 2 trials I'm sure you're familiar with, INTRACT-2 and also ATAC-2, which showed there was a linear association between systolic blood pressure within the first 24 hours and neurological recovery, even at levels between 120 and 130. So in a way, to reconcile some of these differences, what we've done here, we've maintained the focus on hyperacute care for intercerebral hemorrhage, and we've very much emphasised the results of INTRACT-2, which was the largest study, which showed that blood pressure reduction below 140 did provide a clinical meaningful benefit. So the mantra of blood pressure reduction is that it's safe, it's feasible to go fast and intensive, but also to reduce blood pressure variability in patients with mild to moderate intercerebral hemorrhage. So putting all that together, it's really been emphasised that targets are around 130 to 139 within the first hour of blood pressure reduction in patients presenting with pressures between 150 and 220. And you've got various exclusion criteria very much in kilter with the INTERACT-2 study. And then we've acknowledged the point at the bottom, really endorsing that patients with this condition should have rapid access to hyperacute stroke services and require repeat imaging if necessary. And then talking about imaging, we've also emphasised the use of CT angiography within the first 48 hours in patients that have a low risk of uncovering a macrovascular cause. So, my concluding thoughts. I think there's been absolutely considerable advancements in the evidence base for hyperacute care, really since the 2016 guidelines with regards to reperfusion therapies, advanced imaging, taking a very much a proactive approach to managing intercerebral hemorrhage. And I think, in a way, the challenge is now going to be how do we implement these new advances to as many patients as possible, but actually as quickly as possible. So thank you very much for your attention and time. Thank you. So I would like to introduce you to Louise Clark, who's going to give a summary on the rehabilitation and recovery chapter. So thank you, Louise.
Thank you, Ajay. Welcome everybody and hello to everybody on Zoom. So I'm Louise Clark, I'm a consultant therapist based in Dorset and delighted to have been the editor for the Rehab and Recovery chapter. I'd like to reiterate my thanks to all the contributors to this chapter who covered a whopping 29 out of the 59 total questions that we covered in this partial rewrite. Particular thanks to Dr. Rebecca Fisher, who chaired over half of our topic group, so a massive thank you to Rebecca for that, and to our wonderful topic group leads, Avril Drummond, Nicole Walmsley, Cara Lewis, Sue Pownell, Sarah Tyson, Shirley Thomas, and Frederic Van Week. So before we get into the details, I would like you all to jump onto Slido using slido.com and enter the participant code on the screen. Once you're there, I'd like you to answer the question that's posed here. What is it that you're most excited about from the Rehab and Recovery chapter? This will create a word cloud for us to share, and we'll be sharing it after today's event. So 1 to 2 word responses work best, and you can enter more than one. The participation code will be on the next few slides, so there's no rush. So to begin, I just wanted to share quickly some of the changes about how we went about this partial rewrite for this chapter. So there were some changes to the process, the structure, and the terminology that we've used. So we took a decision that all topic groups would have MDT representation this time, whereas historically we had profession-specific groups looking at particular questions. For example, a group of physios looking at walking, for example. This feels overall to have been a really positive move with a broader MDT feel to many of the sections. You'll have noticed also that we've moved away from the alphabetical structure of the previous chapter, and instead we've grouped the domains together to help clinicians to look at the overlapping areas, which we hope is more user-friendly to be able to find information quickly. We purposely have not named specific assessment tools or measures. Instead, we've recommended the use of validated or structured assessments throughout, and this is in order to future-proof the guidance and the guideline in the event of any new measures being developed ahead of the next edition. In psychological care, you'll see that we've given some criteria to aid selection of tools and measures. Lastly, as much as possible, we have not been profession-specific in many of the recommendations. Instead, we've commonly recommended that tasks are undertaken by somebody with the appropriate levels of knowledge and skill, in line with a more competency-based MDT workforce. You can see here on the right that the numbers of recommendations pertaining to named professions is actually very small across such a large chapter. You can see on the slide that we've tackled many new areas or questions this year within the chapter, some of which you'll be hearing more about during this short presentation. All of the remaining reviews were on key areas where the evidence had advanced since the last edition. Arguably, the most important feature of the update is the new section on rehabilitation potential. We're particularly proud of this being up front and centre in the chapter, as we know that it's so crucially important for people with stroke. It also frames how we think as professionals and how we run our services. These recommendations bring us in line with policy, mandating needs-led services, and importantly highlight stroke-related needs as well as goals, which span domains such as adjustment, psychological well-being, education, social participation, management of complications, and management of care needs. This recognises that we shouldn't be limiting services only to those who are making functional improvements. All these domains should be considered key aspects of comprehensive stroke rehabilitation, and therefore we recommend that the term no rehabilitation potential is not appropriate and should no longer be used. The question more so should be, is the need stroke related, and is the stroke team the best placed team to help the person meet this need, rather than a lack of functional improvement rationing access to stroke services. This opens up services to those who previously may have been considered too mild or too severe to have functional gains to make. I'm sure it won't have gone unnoticed that intensity of therapy is another major change in the new edition of the guideline. This is based on the knowledge of sedentary behaviour still pervading and the strengthened recommendations around many of the motor recovery interventions that we've covered throughout the chapter. We do recognise that a change in organisation of care will be required to manage this, looking at a variety of approaches, including group work, open gyms, scheduling, alongside more traditional ways of delivering therapy. This will require a different approach in hospitals and in the community, and the challenges will be different in both of those settings. The underpinning intention behind this is wanting to avoid clinicians having to choose between interventions when more than one intervention might be indicated for a patient, or providing a peppering of interventions at an effective dose. When the intensity evidence was reviewed, in particular looking at the dose and intensity of the many interventions that we've recommended throughout this chapter, in addition with the need for translating motor recovery goals into functional practice, it was really clear that we needed to do more in terms of therapy to be able to get the results that the patients deserve. Importantly, this is a collection of 3 hours of therapy accumulated across the day, focusing on motor recovery. Often this is likely to be a mixture of occupational therapy and physiotherapy, and should be provided at least 5 days out of 7. Other aspects of rehab will still be required alongside this, for example, therapy focusing on cognition or speech or psychological interventions. outside of therapist-delivered interventions, we're keen to see people with stroke remaining active across the day. So you'll see that there's a further recommendation for people to remain active up to 6 hours a day. And that may be achieved through a variety of methods, including self-directed practice, active meal times, using visitors, other ward staff and carers, sitting out, engaging in meaningful activity, all to reduce sedentary behaviour and its harmful consequences. We recognise that there's lots of challenges here, all for a variety of reasons, and that there will be patients who are unable to tolerate these levels of activity due to fatigue or medical status. However, we must really look at ourselves and ask whether this is true of the individuals that are in our care, when activity can be spread across waking hours and provided by a range of people in the MDT, or whether we're making assumptions of people's abilities, possibly clouded by our clinical capacity and historic working practices. To facilitate this, the need for adequate rehabilitation space in inpatient settings is clearly stated in the guideline, as is the increase in workforce that Rebecca has told us about. Measurement of therapy delivery will undoubtedly change in line with this, but you'll be hearing more about that from the SNAP team in due course. It's been recommended for some time that an MDT presence and access to rehabilitation is required 7 days a week across our stroke services. Recommendations therefore now reflect that initial assessment should be completed by therapy within 24 hours of admission to a stroke unit. We have lots of additions and improvements to various sections throughout the chapter, and we're just going to give you a quick selection of some of these now. So we have improvements in balance. So this includes assessing for the various causes of poor balance, including visual changes, difficulties in dual tasking, vestibular issues, and ensuring therefore that the treatment is targeted at those underlying causes. Previously, there was no detail around assessment of balance, only treatment recommendations. We've recommended that people at high risk of spasticity are monitored to identify problematic spasticity and provided with interventions to prevent skin damage, prevent significant difficulties with hygiene, dressing, pain, or positioning. We're thinking here particularly for those with really severe strokes who are in nursing homes or at home with big packages of care, and anticipate that this will be a role that community stroke teams will need to look to deliver. We've recommended that all people with stroke have a structured visual assessment and receive input from orthoptists where people have been found to have altered vision, visual field deficits, or eye movement disorders. We've improved detail regarding screening for and carrying out cardiovascular exercise, reaching appropriate levels of exertion, recommending now that all people after stroke undertake cardiovascular fitness or mixed training once they're medically stable, and that's regardless of age, stroke severity, or time post-stroke. We recommend liaison with other services that offer exercise-based programs, services such as cardiac rehabilitation or pulmonary rehab groups, with regard to integrating those screening processes and sharing equipment, such as BP monitors, ECGs, treadmills, for example. And then lastly, recommending building links with voluntary sector and recreational fitness facilities such as gyms and leisure centres, or considering providing equipment in outpatient departments that people are free to access to enable community dwelling people with stroke to access treadmills and other relevant fitness equipment. The bumper upper limb section now covers a wider variety of interventions, as you can see here on the slide. Just to focus on the key areas of change, we see that electrical stimulation is now more strongly recommended than in the previous guideline for both upper and lower limb, actually, but focusing here on the use of electrical stimulation for shoulder subluxation within 6 months of stroke and to encourage return of wrist and finger extension. Recommendations include ensuring adequate provision of electrical stimulation in local systems, ensuring that staff, patients and carers are adequately trained to be able to use the device, and ensuring that follow-up is in place for evaluating and enabling long-term use, which we know across many services currently isn't there. Excitingly, we see the inclusion of transcutaneous vagal nerve stimulation for the first time being considered for those with mild to moderate upper limb weakness in addition to usual therapy. The recommendations clarify that implanted vagal nerve stimulation should still only be used in the context of a clinical trial at this time, but we look forward to seeing this research develop. In aphasia, we see a shift to intensive speech and language therapy being considered from 3 months after stroke for those who can tolerate moderate to high intensity therapy. The research underpinning this recommendation saw patients receiving 3 to 4 hours of aphasia therapy a week, reaching a total of up to 50 hours across their rehab programme in total. Language recovery was one of the areas which featured really heavily in the tele-rehab literature, and so is specifically recommended here in this section. There is a whole section dedicated to tele-rehab, but it's specifically mentioned again in the aphasia section. And recommending that services have adequate equipment for their local population, that we consider digital literacy and digital inequities across our patient groups, and that tele-rehab programmes continue to include the need for regular therapist review. So moving on to psychological care. This section has been enhanced with more detailed information on the purpose, timing and knowledge required for those undertaking mood and cognitive screens and assessment. This includes recommendations that we should routinely screen for delirium, which was not in the previous guideline, and where reduced goal-directed behaviour or reduced emotional responsiveness persists, we should also screen for apathy alongside other cognitive and mood disorders. As you saw earlier on, apathy is a new area for the guideline and one that we hope to see move past awareness and identification in future editions of the guideline. The recommendations recognise that it's not always appropriate for all screens and assessments to be completed as an inpatient, and that referrals for ongoing assessment should be accepted by community teams, ensuring that people don't stay in hospital longer than is needed and ensuring that people aren't assessed in inappropriate environments which could affect the findings. The important role of neuropsychology runs throughout the guideline, particularly highlighting areas of specialist input required in complex and atypical cases. And this includes the role of psychology workforce in overseeing and ensuring the knowledge and skills of the team delivering a distributed model of psychological care. This can take place for a variety of ways, including facilitating formulation for complex cases and providing training and supervision for all team members who may be undertaking either psychological assessment or any intervention. Moving quickly on to swallow and feeding, there is more detail in this edition regarding assessment and shared decision-making for artificial feeding and the need and timing for dietetic input. We provided clearer guidance regarding the role of fees and video fluoroscopy in assessment for dysphagia. And we are also recommending, for the first time, neuromuscular electrical stimulation as an adjunct to behavioural rehabilitation for those with dysphagia. And I've included some broader MDT recommendations also around feeding, including postural support, environmental considerations. And lastly, on this topic, ensuring that patients are referred to pharmacy for review of medication formulation. We did have some important areas where the evidence base was less strong, meaning that we made some consensus recommendations, and some of the key areas that we'll just run through quickly now are listed here. So return to work is an area we know still requires improvement. We know this from patient feedback, national data shown here, taken from the 2022 SNAP annual report, and from its remaining prevalence in national policy. The return to work section has a raft of additional consensus recommendations, with recommendations focusing on addressing this topic much earlier, providing support and information in the acute stages. The section gives more detailed information on how teams should work to support people to return to work alongside employers, and now also includes the use of footnotes. Fatigue is another section which has been significantly expanded and is another area where we have high reported unmet need from people with stroke. Here the focus is on ensuring skills and knowledge within the team, the need for fatigue to be assessed routinely to identify and manage various triggers, and recognises the need to consider physical and psychological fatigue alongside other things such as coping styles and the demands of the context. A range of interventions are also suggested, as well as the need for information provision across pathways. Clearly, this is a really important topic to consider in balance of the need to increase therapy intensity, and will require individualised rehab programmes to help manage people's fatigue, shared decision-making with patients as we negotiate what their programmes look like, and mindful planning and pacing of activity. Moving on to discharge from services, we know that people with stroke describe feeling abandoned when discharged from stroke specialist services, and it can feel like dropping off a cliff when moving on from our teams. The chapter addresses planning and timing of discharge from rehab services, promoting weekly reviews of whether patients remain on the right pathway, and that the outcome of those discussions being shared with patients along the way. Shared decision-making and planning from the point of somebody coming into your service as to how long they're likely to be with you and what discharge will look like and when that's likely to be. And importantly, ensuring that information is given on how to re-access services and how to do that and when it's appropriate. Last but not least, it's recognised that provision of formal structured reviews remains patchy across our nations, as seen here on the graphic from the recent SNAP annual report. Recommendations continue to require comprehensive reviews for all patients at 6 months and annually thereafter, with a primary focus on identifying unmet need and reaccessing services as required. We've reiterated that review should be holistic in nature, reviewing all of the aspects of rehabilitation and life after stroke that we listed earlier on when we were discussing stroke-related needs, and that they should be conducted by professionals with an appropriately wide base of knowledge and skill to undertake these holistically. This is purposely to open the doors for a range of professionals to be able to undertake these reviews. To finish, we know that there are some really big ambitions in this chapter. We hope that over the coming years we can continue to work together as a stroke community, get behind the evidence base and to continue to push the bar for rehabilitation. We look forward to seeing this being implemented and to patients receiving what they want and what they deserve. So thank you very much. I'm going to hand over to Professor Martin James, who is going to give us an overview of long-term management and secondary prevention. Thanks very much.
What a fantastic summary of the way that the evidence has progressed in stroke rehab. And great for Louise to manage to squeeze it all into the time allowed. I'm not a therapist, but if I was a stroke therapist, I'd be really excited at this point about the potential offered by the new evidence and the new guideline recommendations. So over to you, therapists, to pick up the baton and run with it. So I'm going to talk now about long-term management and secondary prevention and just cover the key updates in that important chapter. We'll be looking at antiplatelets and anticoagulants, lipids and blood pressure, investigations for AF, PFO closure, and then new areas in the guideline about cerebral amyloid angiopathy and CADASIL. In fact, these were sections that feature for the first time this time round and weren't even in the version that Deb was reading by candlelight under the covers when she was working for Anil Sharma. And then touching again on physical activity, as Louise has done, and talking about further rehabilitation and how we support people to resume their lives after stroke. The importance of secondary prevention of vascular disease is been rediscovered, if you like, by the joint chief medical officers of the 4 UK nations who wrote this leading article in the BMJ about a month ago about, I don't want to be cynical, but about the sudden realization that there's all this disease out there that could be better prevented. And of course, pivotal to our thinking as stroke doctors, stroke physicians, is that 25% of all strokes are recurrences. So there is a massive group of patients who are sitting ducks for another event. And of course, if you talk to people with stroke, that's one of the principal things that they're worried about. Will it happen again? So we must make no apologies for redoubling our efforts in the prevention of recurrent stroke and, of course, prevention of stroke after TIA. They say, if you can just read the small text in the bottom right-hand corner, numerous areas of clinical practice still lack evidence-based approaches to secondary prevention. Well, not stroke. We've got plenty enough evidence now about what to recommend to reduce people's risk of recurrence. So first of all, in antiplatelet treatment, this is an area, of course, which has moved on significantly since 2016. There have been many important antiplatelet trials since 2016, some of which, of course, like TARDIS, have shown just how we're butting up against the very margins of the balance of risk and benefit for antithrombotic treatment compared to prevention. So in many ways, although a study like TARDIS isn't leading directly to a recommendation, it's still fleshing out our understanding of just where we are on that balance, that scale of risk and benefit. But we have had other trials which are caricatured as positive trials of dual antiplatelet treatment, including, of course, clopidogrel and aspirin, which in individual patient meta-analyses suggested that you got pretty much all the benefit you got from combination treatment in the first 21 days from the prevention of recurrent events. That's chance and point, of course. And then Thales, looking at ticagrelor and aspirin. We feel aggrieved that the cardiologists have got the monopoly of all those extravagantly expensive antiplatelet agents, and it's time we had one of our own. And we've picked on ticagrelor in combination with aspirin for 30 days, again as reducing the risk of serious recurrence after minor stroke or TIA. And there is obviously nuances about what it represents a minor stroke among those studies. And again, we do see that the use of dual antiplatelet treatment does increase the risk of intracerebral hemorrhage. So we have to carefully pick our winners, those who are at lower risk or have got good management of their other risk factors such as blood pressure, so that they are the people who will benefit the most from the early, within 24 hours, introduction of dual antiplatelet treatment. And then, of course, matters have progressed also in the reintroduction of antiplatelet treatment, at least after intracerebral hemorrhage, for patients who would otherwise be justified for antiplatelet treatment. And obviously, much of our understanding of that comes from the RESTART trial. So for the first time, the guideline is recommending that patients who do have spontaneous intracerebral hemorrhage whilst taking an antithrombotic may well be considered for restarting it again beyond 24 hours, although, of course, in RESTART, the average time to recommencing antiplatelet treatment was much longer than that. It was of the order of 70 to 90 days. But we have, for the first time, got some clarity from randomized trials about what we should do about people who appear to be justified for either withholding or restarting antiplatelet treatment, at least. And then, of course, we have had trials, mainly from the Far East, looking at clopidogrel resistance. We don't have trials in the West, so we don't know what role clopidogrel resistance may have in people who appear to have recurrent events whilst taking clopidogrel. But at least we have some alternatives in that ticagrelor is not subject to the same cytochrome pathway as clopidogrel metabolism, which is affected by the mutation. Now, for anticoagulation, we've got new trial evidence about what to do about introducing anticoagulation after a cardioembolic stroke. And also on the right here, we've also got high-quality data from CHROMIS-2 trial, among others, about the role of cerebral microbleeds in the decision-making process about the use of antiplatelets or anticoagulation after cardioembolic stroke. And we know from the very large-scale MICON analysis that really, irrespective of the number of microbleeds or their location, either in a lobar or in a deep position, it's very likely that they shouldn't be persuading us or dissuading us from the use of appropriate antithrombotic treatment for vascular prevention. In other words, if you see a scan like that, there isn't yet evidence to say that you shouldn't proceed as if you hadn't seen the scan and proceed with antithrombotic treatment. And of course, that's been a controversial area, and we await the outcome of large randomized trials. As far as introducing an anticoagulant, and in this instance, almost exclusively one of the newer DOACs after cardioembolic stroke, we have seen trials in mild stroke, the timing trial of people with an average NIH stroke scale score of 4 in timing. The recommendation is that they should be considered for patients with mild stroke earlier than 5 days. But I plead with you not to pass up the opportunity that we still have in our hands to finally get a definitive answer about what to do for moderate to severe stroke. If the NIH stroke scale average in the timing trial was 4, we know that the average NIH stroke scale severity for people in the UK suffering a cardioembolic stroke is actually 7, so a good deal more severe than we're seeing in the timing trial. And what we mustn't do is allow that sort of creep that goes on about pushing at the edges of what we truly know about what's beneficial for these patients, and we should focus on getting a result from a large randomized controlled trial of people with moderate to severe stroke about the timing of introduction. Now, I know many of you watching and many of you in this room, because there are 85 centres in the UK participating in Optimas, which is intended to proceed until the end of the year, in order to finally recruit sufficient, over 3,000 patients, timing was 1,000 patients, over 3,000 patients to get finally, once and for all, a definitive answer about the timing of anticoagulation after stroke. So don't let's pass up that opportunity by some sort of creeping encroachment from extrapolating other data. Lipid management has also moved on significantly since 2016, particularly through the treating stroke to target trial in 2020 of a lower lipid target and a manageable lipid target defined by non-fasting, non-HDL cholesterol. So gone is all the shenanigans about fasting. You can just measure non-fasting, and your target can be defined according to non-HDL cholesterol below 2.5. And TSTT and its subsequent individual patient meta-analysis showed that there are substantial benefits from vascular prevention from giving people with stroke and TIA a lower target. And of course, in order to achieve those lower targets, we've got to be more intensive with our treatments. Perhaps it might have been said once that statins were a kind of fire and forget treatment. You give them a prescription for any amount of statin and you may never see them again and they'll get the benefit. We know that's not the case. A year on, not an hour, a year on from stroke or TIA, 25% of people have stopped taking their statin. Most of them, of course, Daily Mail readers. And we need to save the lives of Daily Mail readers. That is our mission. And we need to do that by following up on cholesterol, ideally after as little as 4 weeks, escalating the dose further, using high-intensity statins, principally atorvastatin, of course, enjoying the renaissance of ezetimibe. 2/3 of the people in TSTT were taking ezetimibe as well as a high-intensity statin. So adding in ezetimibe promptly and early, and of course in those nations where these are approved, and they're not in the Republic of Ireland, but using injectables as well. And inclisiran comes extraordinarily cheaply and is extraordinarily effective in reducing cholesterol, and we should be using these to get cholesterol down. And indeed, the rapid adoption of these sort of targets for the prevention of vascular disease is key to NHS England's objective of preventing recurrent strokes and heart attacks, following the red column here for secondary prevention, which takes you very quickly through high-intensity statins to ezetimibe and subsequently to the injectables down there in the bottom right corner. And very helpfully and usefully, there is a companion pathway for statin-intolerant patients, because there is much that we can do, and these are recommended in the guidelines, to get people who are ostensibly intolerant of statins onto some form of effective cholesterol-lowering treatment. So that's a key message in the updated guidelines. As far as blood pressure lowering treatment is concerned, of course, we treat people with the quintessential blood pressure sensitive disease, stroke, ischemic stroke and hemorrhagic stroke. So we make no excuse for having a lower blood pressure target for people with stroke and TIA than is recommended for the generality of vascular patients by NICE. And we recommend a blood pressure target, as we did in 2016, below 130/80. But we're promoting here, and this is Kailash Krishnan's group who looked at this evidence, promoting here the increased use of ambulatory and home blood pressure recordings to guide and empower patients to do the same thing, move themselves up the scale of antihypertensive treatment until we're getting really effective stroke reduction from blood pressure reductions below 130. And there are a few specific circumstances where that might not be appropriate. But concern about side effects from antihypertensive treatment should not be discouraging us from implementing a treatment that we know, and we've known for more than 20 years. It was the Progress trial in 2001 that told us this. A treatment that we know dramatically reduces the risk of recurrent stroke. It's been rather more difficult to tease out what to do about pursuing the possibility of occult paroxysmal atrial fibrillation in patients with ischemic stroke. But of course, we have seen increasing evidence about the role of implantable loop recorders and other devices, wearables and so on, in finding those patients with atrial flutter and fibrillation who are ostensibly in sinus rhythm when they had their stroke. The recommendations recommend a staged approach, beginning with 24-hour tape for most people, and this was Ronan Collins's group that looked in an enormous amount of detail at the enormous amount of evidence in this area. But where a persisting suspicion of occult paroxysmal AF persists, then further investigation using implantable loop recorders or wearables should be considered. And this is on the basis of pretty recent meta-analyses. In fact, since we published, there has been the publication of yet another systematic review and meta-analysis, again from Georgios Sivgoulis' group in March's ESJ. And they reviewed the evidence not just in stroke and TIA, but in vascular patients in general. And it is indeed the case that the more monitoring you do, the more AF you pick up and the more people end up on anticoagulation. But they still did not find an association between prolonged monitoring and stroke TIA recurrence, partly because still a great deal of this evidence is from people who don't have stroke or TIA as their qualifying condition. Only about a quarter of the people in this study had stroke or TIA as the qualifying condition. So even one of the foremost European exponents of prolonged monitoring, Sivgoulis, is still recommending that randomized controlled trials are warranted to finally nail down the question about whether doing all this is A, cost effective, and B, prevents more strokes. Patent forum and Whiteley is interesting, perhaps not least because since 2016 there has been a 180-degree turnaround in the recommendation about intervention for PFO. In 2016, it was in our Choosing Wisely chapter about something that you shouldn't be doing routinely and should be thinking very carefully about recommending. Since then, we've seen 4 randomized trials and 70 systematic reviews. So hats off to Ronan Collins and his team for looking through 70 systematic reviews. Most of them, of course, saying pretty much the same thing. So there's another example of research waste in that could have probably been 2 systematic reviews would have nailed it and all the others were superfluous. But they waded through dutifully all that evidence and came up with the recommendation that people below the age of 60, in whom investigation shows it to be of otherwise undetermined etiology, should be recommended for transvascular PFO closure if they have either an atrial septal aneurysm or a right to left shunt, or indeed both, within 6 months of the index event. We thought that was reasonable time in which to get it all discussed, particularly investigated and discussed, particularly as the recommendation should still be a multidisciplinary recommendation, taking account of the cardiologist who will be doing the procedure, the stroke physician who's seen the patient, and weighing up the acknowledged adverse effects and complications from the procedure. So as I say, we've got new sections on relatively new diseases, and David Waring and his colleagues brought their international expertise to bear on these new disease areas, including cerebral amyloid angiopathy. And as one might anticipate from a bunch of expert academics, they felt that the most important thing was more trials, of course. As we characterised these new conditions and understood their phenotype and their genotype and their risk profile, we definitely need more research studies specific to these disease areas. So cerebral amyloid angiopathy, yes, we should be considering all the traditional things that we consider might be appropriate, and perhaps some other things that might help to avoid the use of antithrombotic treatment in a group of people at substantially increased risk of intracerebral hemorrhage. But we do need more trials. And in CADASIL, very much the same. It appears appropriate to look at intensive risk factor management, particularly for blood pressure and smoking and things. But again, translating the evidence that we have about microbleeds, we should be considering antiplatelet treatment, perhaps when people with CADASIL have at least had stroke or TIA. New areas, much more research needed. And then Louise has touched on this in some detail. But we must not presume that secondary prevention is all about taking more tablets, although, as far as blood pressure is concerned, it very much is. But it's not, and we're trying to restore people to physical fitness, or introduce them to the new concept of physical fitness through the use of cardiorespiratory or mixed training. And of course, we're now in the realm of the transition from patient to person. We're moving people from the realm of health services and patients to self-management and taking their lives forward after their stroke. So equipment and facilities should be made available, but not necessarily in healthcare facilities. And indeed, there's something to suggest that this should be outside traditional statutory health services, using people like fitness trainers who've had additional training. And also, of course, this crucial collaboration, which Louise alluded to, with cardiac and pulmonary rehabilitation. There is basically the objective of all three of those to improve and recover cardiorespiratory fitness after stroke in order to reduce the risk of recurrent vascular events is broadly the same, and we should be exploring the opportunities for overlap that occur there. And then Frederica van Vick's expert group cogitated long and hard over the issue of further rehabilitation, and certainly continue to recommend reviews beyond 6 months. It is now 16 years since the National Stroke Strategy in England recommended reviews at 6 months and annually thereafter. We've now reached the princely level of 38% of people being recorded on SNAP as having a 6-month review. So what's that? We've got another 34 years to go before a decent number of people are receiving a review and a holistic, multifaceted review of their needs beyond 6 months as they try to restore and recover and rebuild their lives. Further interventions are appropriate where goals can be identified, and we must support people with that transition. And support means more than just issuing them with a leaflet. Support means how do you give the support that people will need to transition to their own self-management plan, and to enable and empower them to both reduce their risk of recurrence, which, as we said, is one of the great concerns of people with stroke, and rebuild their lives again after stroke. So those are the main thrusts of the chapter, which could be summarised in a single word, which is more. We need more for our people with stroke. We need more intensive antiplatelet treatment. We need more intensive lipid and blood pressure management, which essentially is about how to achieve lower targets. More people are eligible for PFO closure than are recommended in 2016. More people are warranted for prolonged cardiac monitoring, often using something like an implantable loop recorder. More research is needed so that we can get better at targeting prevention for people with CAA and CADASIL. And we need more facilities, equipment and support for physical activity and to make that transition to successful self-management for our people with stroke. So that's my whistle-stop tour of Chapter 5 on long-term management and secondary prevention. In fact, that concludes our four-cornered summary of the key changes and updates. I hope you are as excited as we have been as guideline writers by the potential and the opportunities that this presents. We're going to pause now for a key element of this before we then move to a panel discussion about how we're going to go about implementing this in the future. But before that, I want to draw your attention to what we call the plain language summary. You have one in your tote bag. And as I say, on the resources part of the website, you have the potential to print off an unlimited further supply of these for all your patients. And this, which is an update to what we produced in 2016, but it's an impressive update, and it is a massive effort from Marney, who's here in the room, and from Emily Toplis, who's going to be joining us on Zoom, and from Liz Thomas, who is married to a stroke survivor, and her caring demands mean that she's not able to be with us today, along with a huge amount of help from Jennifer Butt and from Jan Stanier, to produce what I hope you will agree will be a very useful guide to what should be proper stroke care for our patients and their families. So, Marney, I think I'm handing over to you at this point because you're starting off in the room and Emily will be joining us on Zoom.
Thank you. So I should be starting this and then we'll move to Emily online. So hopefully that will be a smooth transition. So here we have the front cover. The focus, as in 2016, is on what, when, why. It was a strong structure supposed to explain what needed to happen, why it needed, when it needed to happen, so lots of things time limited, and why, so indicative of the research basis. We've borrowed this what, when, why for the presentation to draw your attention to some of the aspects. So why do we need a plain language summary at all? Well, you'll be familiar with lots of people who've had a stroke and of their families saying that they need more information. So sometimes they do literally need more information. Sometimes they need time to digest it and something to refer to. Sometimes they need reminding of something they've been told and have forgotten. So this document, it's hoped, will fill some of those gaps. It helps people work out what it is that's happened to them when they've seen a series of people in quick succession for processes that they're not familiar with, and buildings where everything is new and everything's a whirl if they remember it at all. And it helps orientate them to how the journey will progress, where they're going and why. And information also helps empower people with stroke and their families and friends. It helps them participate more effectively in the process. They can prepare questions before they know they're going to meet someone. They can write it down to make sure that they don't forget things that they need to ask. So here's the contents page. It's divided up as per the patient pathway, approximately after the introduction. It has sections that are likely to be of particular interest, so the information's been brought here together as a reference document. And as I've said, it stresses what's going to be done, when, and why. So each page has these boxes, the what, when, why boxes. It's been prepared using bold for key words. So this is to help people with aphasia or other cognitive problems after their stroke. So you ought to be able to read and understand the essence of it just by picking out the bold words. So the Stroke Association did that for us, and it's been very nicely completed. So there are just 3 sections for you. There's additional information at the end. There's quite a large glossary section. Patients and families do need to come to terms with a lot of very specific words. We'll create words in order to specify meaning, and patients and their families do need to get on top of that. It's not enough to say, oh, well, we'll just explain every time. If you give people the word they need, they can then start using it themselves, which, again, improves understanding by being specific. There's a selection of charitable organisations and other support organisations there across the UK and Ireland, so people can find somebody local to them as they move into the rehabilitation section and life after stroke beyond. There's a section if people feel unhappy that the care they're receiving is not what the guidelines seem to be indicating, how they might go about exploring that, and it does always start with speaking to the team who are providing your care. There is also a link to the full guideline for more details. So you start with the light version that's in your tote bag, and then you move on to explore other specific areas relevant to you in the main guideline, if you wish. So when should it be used? Well, it can be given to people very early on. That's why it's been created, as I said, with this bold text, and it's supposed to be aphasia-friendly and so forth. So if people have questions or they want to prepare questions, this is a good document to familiarise people with before. It's very useful for staff to use with a patient or to talk to a family to explain what might be coming up or about choices that might be made, or things like the review to look out for in the future to see if we can up that 38% figure, to make this sense of what happened at the beginning that nobody remembers. So lots of use. Here are some pictures, because I'm the only one, well, Jennifer's in the room, but the other patient voice members, I'm the only one in the room. So I'll be handing you to Emily in a minute. She likes to style herself as a stroke thriver rather than survivor. And Liz, who's caring today for her husband. We had a lot of help from Jan, from Sign, in helping us decide what should go into the plain language summary, and Jennifer, of course, kept us all on track and rounded things up and wrote endless versions of things, and in particular added, with very good will, days of work after I suggested that all significant patient support organisations ought to be consulted over the preview, which was good in that it generated lots and lots of comments, but of course a nightmare to then edit and follow up on. And Sign designed the PDF, so that, as we've mentioned, you can print online or from online, and Itineris have produced the online version. So it is expected that all those sections, or perhaps even whole ones, may be printed off, that online is going to suit a lot of people because it allows for the size of the text to be enlarged. It allows for text readers to give you the information. It allows people to personalise the use of it for themselves, whatever suits. So I think the next slide is when we move to Emily. And I'm not sure if I'm needed to move the slides on when Emily wishes, or I think she's going to. Okay. I think she will be saying next slide, please. So I'll sit down.
That was Emily, but she was going to try and speak, I imagine.
I'm very. I think I'm almost set up to do my best Chris Whitty when I need the slide changing. But my name's Emily. As Marney said, I describe myself as a stroke thriver. I had my stroke in 2013, and I'm now working as a peer support worker within the Northamptonshire Community Stroke Service as part of their NHS England funded rehab pilot. And a big part of me being comfortable describing myself as a thriver is down to doing the job I'm doing now. And my aim is linked to a lot of what the previous presentations have been around, is around we should be aiming for thrival after stroke because survival's not enough. Right, next slide, please. So it's going on with the what, where, when, how, who headings. How is it produced? Sorry, can we go back a slide? I missed one. Sorry. In terms of how it was produced, we started in 2022 with the 2016 patient version and had a small focus group to provide feedback on what they thought about the original version. They basically came back and said they like the what, when, why format, and if it ain't broke, don't fix it. So we then used what was in that 2016 version and reviewed it for up-to-dateness, to take into consideration all the developments that were included in the new version of the full guidelines, to make it relevant to all 5 nations, and to make sure that the language was clear and understandable. And the bulk of that work was done by Martin. As we say, Roberta from Sign was involved in it. And once we'd got the draft of where we thought we were going with the updated version, we distributed to a number of patient organisations and received a very, very large number of comments and feedback from that. So we had very enthusiastic engagement, which gave, as Marney said, which gave Jenny a bit of a nightmare to then incorporate those. Next slide, please. In terms of how it was produced, it's been produced in order to be available in a number of formats to increase accessibility. Primarily, we're looking at it being used as an online version, and all the design is based around accessibility and being aphasia friendly in terms of using the bold typeface, the colours that are being used, and the PDFs and website versions being accessibility standard friendly in terms of website readers and things. And the big important thing for me is the change from the title from patient version to plain language summary, in terms of the fact that it's use of plain language to make it accessible to everybody. So not just those that have had a stroke and have got aphasia, but general population, just to avoid, so that anybody that's not a clinical or stroke professional has a version that is accessible for them. Next slide, please. So where can you find it? Primarily, we want it to be accessed online, and from the main guideline page, there is a link to the plain language summary version. So it'll be able to be read online. There's a PDF that can be downloaded. There's a poster that can be downloaded and printed, and that poster has a QR code to allow people to access the online version. And there are print-ready PDFs available on the website, so that anybody that wants to print off their own hard copy version can. The small number of print copies, I'm assuming most of those are the ones that are with the guys that are actually in person at this launch. And there is also a leaflet that will be printed, and that, my understanding is that the Stroke Association's information pack will include that leaflet, so that anybody that has access to that information pack will be notified and find out about the plain language summary, to be able to access it online and print off copies if they want to. So next slide. So what can you do now? You can use the A4 poster, print it off and plaster it anywhere that anybody that might be interested in finding out about stroke can download the QR code and access it. My thoughts are backs of toilet doors are always good places to put posters, so that people can then download the online, the PDF, and read it. Distribute the leaflets. Use it in clinical practice. As has already been said, it's a superb tool to be able to facilitate conversations with patients and family members, to explain things in language that's understandable. And the other things that we're asking people to do is use social media. Tweet about the fact that there is a version that's a plain language version available for people that are not professionals, not clinicians, not therapists, to be able to understand about stroke and what the guidelines require. Use it, advertise it in your organisation's newsletters, and get copies printed and circulated to patient forums and patient groups. So basically, tell the world and keep telling them. And as far as we're concerned, your imagination is the limit of what you can do now to spread the word about this plain language summary. Next slide, please. When can you do it? Tomorrow. Or if it's involved in publicising it on social media and you've come on the train, do it tonight on the way home. Next slide, please. And why? Because it's important that people like myself have access to information about stroke what's happened, what to expect in language that we can understand and is accessible for us. Thank you. That's the end of mine, and I think I'm not sure who I'm handing over to now for the next section.
No, that's fine, Emily. That's terrific. Thank you. So if you missed any of that, then the key thing is it's there to be used by clinicians and patients and the public as widely as possible. So we're going to move on now to a little session with our Q&A panel. We're going to have representatives from all 5 participating nations. We're going to have Ronan Collins looming large on the screen. And we're going to have Will Whiteley from Scotland, Deb Lowe from England, Shakeel Ahmad from Wales, and Patricia Gordon, who I might have seen, Patricia, from Northern Ireland. Come and take your seats, and they'll turn up your mics. And if you've got a question for the panel, put your hand up. Bearing in mind that they're not the people that wrote the guideline. These are the people who will give you an opinion and some advice about the implementation of the guideline. And that's what I think our discussion at this point should be principally about. We've heard it all, we've seen the update, and now we're going to talk about implementation. So, let's have a look at some questions in the room. I can invite you to put your hand up. Or I can go to Zoom, or I can go to some other questions that have been submitted to me in advance. We've got yes, let's start then with a question up there in the far left corner. There are some roving mics, so a mic will rove to you. The gentleman in the white shirt there, that's it.
Thanks very much. I'm Mark, a trustee of a stroke group in Harlow in Essex. I was wondering, why is that 6-month review figure so shocking and appalling? Or what's been done to improve it, and when? Because 38% is shocking and appalling.
So, cutting to the chase with the first question. What can be done? Let me translate it into politic phraseology. What can be done to improve the rate at which we review people, particularly as we've learned that those 38% who attend are a biased sample. So there are people with severe disabilities who are missing out on reviews. Suggestions from the panel about how we might go about 17 years on improving the rate of people who get followed up at 6 months after their stroke, and that's open to any panel member. Deb, go for it.
Yeah. Really good question, thank you, and absolutely agree it's not good enough. We do know that, certainly within England, 3 years ago, we introduced an incentive, something called a sequin, looking at the 6-month review, and we did see an increase in the number of 6-month reviews. But I quite strongly feel that within the, if it's not formally audited or mandated, people don't always feel the incentive to do it. That's not necessarily how we should be delivering healthcare, but we know that's how it works at the moment with hard-stretched services. So I think a mandated 6-month review where data needs to be entered into a national audit would be helpful. Also as well within, there's a conflict at the moment between who should be doing that 6-month review, whether it should be delivered in hospital services or in the community. We found when we visited all 120 stroke services across the country about 3 years ago, that there was a wide, unwarranted variation really between how the review was being done. We know doctors aren't very good at doing the 6-month review generally, or nurses and therapy staff and community staff, whether it's stroke association, voluntary service, as long as you're trained, capable, and it's holistic, do a much better job than doctors do. So I think there needs to be less protectionism around who does the review, and it's the people that are trained to do it in a very standardised way, using tools that we know are effective. So I'm hoping that with this renewed focus within the new guidelines, there's a real opportunity for each individual service to have a look at how they're delivering it at the moment. It doesn't need to be resource intensive. It's often about looking at the right person doing it. And also, there's a real focus on having open access to a review. You can put a benchmark, a stamp at 6 months. 6 months isn't right for everybody. And I think that's a problem sometimes, that a review might have happened at 4 months or at 8 months and not at 6. So this has to be stroke survivor led as well, but monitoring that within an audit setup is really, really difficult. So let's make sure that it's needs based, not just to tick a box, and let's make sure that it's holistic, but we must do better.
Thank you, Deb, for rising to the challenge of how we improve follow-up and review. I'll take a question from Zoom, and in fact I'll expand it a little bit. We heard heard from Ajay about tenecteplase, and just if we put the worldwide shortage of tenecteplase just to one side, what do the panel think about the idea of moving a wholesale switch from alteplase to tenecteplase?
So shall I take that one?
Yeah, well,
yeah. So Ajay and I wrote this part of the guideline. So of course there are advantages to emergency department services to using an agent that can be given quite quickly, allowing a patient to move between hospitals without an infusion for thrombectomy and reducing nursing time for the delivery of an agent. So in my view, it would be very reasonable for a service to decide to move wholesale to thrombectomy, to tenecteplase. The problem, we currently face challenges in the availability of thrombolytics thanks to problems with a major supplier. But I myself think there are many advantages in using it.
Any other observations from the team? Shakeel?
Yeah, so yeah, I totally agree. I think that it'll reduce some of those delays in the pathways. I just went to a talk recently where one of the chaps from Sweden with a quite substantive thrombectomy rate, and they said one of the key areas was having tenecteplase available, and then then the patients then can be moved to the appropriate centres to have the ongoing thrombectomy. So I think as this emerges, I think it'll probably become pick up more routine practice.
Patricia? Yeah.
I would agree with the panel then as well, but I think we do probably have to look at how we rationalise the use of tenecteplase. For us using the drip and ship model to the mothership, does the mothership really need to have tenecteplase? Is it something that really should be for the primary stroke centre to use in order to reduce those delays in getting the patients then to the mothership? Because part of the problem in the delays is often getting a nurse then to go with the patient who's got an infusion going as well. So we need to see which patients need to use it and where it should be used sensibly as well.
And that may well be the case, of course, even when supplies come back online, they may continue to be limited. Were you going to make a point about when supplies might support a transition?
I mean, certainly conversations with the Boehringer Ingelheim global team have suggested that really until the end of December next year there's going to be a shortage. But I think there's a real risk in us looking at once the global shortage has passed, us having a split between using the two agents. I would hope in 2 years' time, when there is no shortage, we will have done a lock, stock and barrel move over to tenecteplase.
Yes.
And we are having conversations with medicines management at a national level to try and make sure that that's actually planned for in terms of supply and demand.
It's funny, isn't it, about what obstacles get in the way of guideline implementation. Talking about obstacles in the way, again, I'll take a question from Zoom, and unsurprisingly, it's about dose and intensity of rehabilitation. I think that's one of the prominent changes in this latest edition. So perhaps, just to avoid us getting bogged down, if we put the issue of staffing to one side, if we can, I mean, that's a bit of a sort of mental trick that many planners are engaged in. What do the panel think that is the second most important obstacle to overcome when we're trying to increase the dose and intensity of delivered therapy?
Well, I think one of the obstacles has to be environment. So how can you deliver intensive patient need, to meet the patient's needs in a very small environment? So the good thing I think about the guidelines is that it allows us to use our imaginations, that we can increase our links with the community services that we maybe have been blinded to in the past. Communities are very close-knit, they know what's available to them, we don't, so we need to listen to our communities to see what we can use locally then that will best meet the patient's needs. And some of the things that we will have to overcome are transport issues, which can be very challenging for very complex needs patients, and we need to look at that and how we can get round of that issue. Equipment to upscale community centres, leisure centres, to be able to facilitate them additional rehabilitation needs. So I think it can be done. I don't think it needs to be very cost heavy. I just think it needs to be imaginative.
Ronan, we've got you looming above the panel in sort of godlike format. But when we consider the obstacles that Patricia described in the north, of course, you encounter those in the south. What would you see as the principal things holding back implementation of those dose intensity targets in the south of Ireland?
Godlike format, that's an interesting one. I apologise, first of all, I'm not with you all in person. And secondly of all, I'm just looking up, maybe I should have tidied up my little attic office room, which looks rather a bit of a mess. Speaking of the environment, as Patricia mentions, I think the environment in the setting of rehabilitation is probably the major barrier here in the south of Ireland as well. I do think, though, that the pandemic has taught us a lot about what we would have considered as the traditional rehabilitation environment, or even the means of delivering such rehabilitation. And I was quite taken by Louise's extensive overview of the rehabilitation guidelines to nod towards telerehabilitation, to nod towards looking at more innovative ways, even group settings, even a nod towards using gyms to an extent maybe for doing some of our rehabilitation. Certainly in Ireland, for example, if we look at early supported discharge, we have some similarities in Scotland in that we've large rural, sparsely populated areas. And certainly when we try and implement early supported discharge in those areas, we have several models of using community centres and telerehabilitation areas in the community. So that does, to an extent, get around some of that environmental barrier. The other barrier, I would say to you, is not just about the staff, but the staff time. Some people in the audience, I think Rebecca may have been at a talk with me many years ago, where I heard a presentation from a colleague in Belgium, whose name has just gone out of my head, Willem. But in any case, the amount of therapy time that we in the UK and in Ireland, if I use our very similar health services, the amount of time therapists spend writing. And this is an issue, I think, as well, that if we try and extend the amount of patient contact how do we deal with this obsession that both our countries have with note-taking and extensive note-taking? And can we standardize it a little bit? Because that is a major limitation, I find, in trying to meet Louise's challenge and Louise's work group's challenge. And I'll finish with this comment. It is a challenge. Many people of all the sections in the guideline, the people that have come to me most have come to me about the rehabilitation section, or restoration to living, as it's called in our national strategy, and have said to us, listen, are we going to be beaten up here, even by legal system, if we cannot give a minimum amount as recommended in the guideline? My retort to that has always been, of course, you must set the bar. All guidelines give evidence base, and they set the aspiration, and they set the bar, as Louise eloquently said, to meeting both our patients' needs and their deserved expectations. So I think that is a thing. But in order to achieve that, it's not just staff. It will be a little bit about environment, but it's also making sure that staff time is used efficiently. Thank you.
Thanks very much, Ronan. Okay, I think in the interest of time, I'll draw that section to a close. But I think even just scraping the surface there of some of the challenges that we're going to be faced, I think we should grasp the nettle and rise to the challenge because of the evidence that underpins it. But I don't think we should sort of pretend that those challenges are not there, and principally around dose and intensity and the transition to new treatments. Right, well, thank you very much, panel members. We've got two final duties to complete before we finish. First of all, or second of all, I'll say a few words right at the end. But first of all, I'm delighted to welcome Juliet Bouverie, who is Chief Executive of the Stroke Association here. And as I was saying at the start of the meeting, it would not have been possible to have produced this update to the guidelines without the support and help of the Stroke Association. So we're immensely grateful to them. And in return, I thought it was the very least I could do was give Juliet a few minutes at the end of the meeting for some closing comments.
So afternoon, everybody. It's absolutely lovely to be here, and this just feels like such a safe environment to be in compared to the meeting that I've just come from, which was at Department of Health and Social Care, quite the most bizarre meeting, where apparently we just need to work at greater pace. We need to get those interventions out over the next 12 months. I wonder why. So I just really want to land three key messages. Sorry, was that very political? Of course, I'm apolitical.
We're recording.
So I just wanted to land three key messages. And the first is just a massive, massive congratulations to everybody involved in this publication. I mean, I remember Martin sort of saying, I think it was probably 3, maybe even 4 years ago, we're just going to do a light touch refresh. It's not going to be a big deal. And it has been a big deal because there's so much new evidence that's emerged since 2016. It's so exciting. But it has been an incredible accomplishment because you've all done this on top of your busy day jobs. And, you know, we're acutely conscious in the Stroke Association of how tough it is on the front line at the moment. But you've also done it in the face of just a minor thing called a global pandemic. And it's quite extraordinary that, A, you've managed to update this guideline so comprehensively, B, that it now covers all 4 countries of the UK, and it really is fantastic that we've now got consistency in our recommendations for Scotland as well as for England, Wales, Northern Ireland, and also that includes the Republic of Ireland. And I think that is just such a phenomenal feat. And the number of partners who've been involved in this collaboration, I mean, you've probably gone through them earlier, but, you know, I was just listing some of them. The RCP in the UK and the Republic of Ireland, NICE, Health Improvement Scotland, all the Royal Colleges through the Intercollegiate Stroke Working Party, the third sector, numerous patients and carers, and I don't think we'd be here today without our fantastic patient voice representatives. So I just want to say it's an amazing achievement. I know Martin won't want me to draw attention to him, but I think we owe Martin James a huge vote of thanks because he has coordinated and orchestrated all of this. He has read every single page, and not only has he read every single page, he remembers every single page. And I think the other thing that's really exciting about the publication is it's so patient-focused. It really does focus on the outcomes that matter to patients. So supporting patients to return home, supporting patients to get back to work, to maintain independence. You know, the recommendations around rehabilitation should be, you know, not time-based but needs-based. And it's fantastic, but stroke survivors tell us all the time that their recovery never stops. And it's just fantastic that the guideline is reflecting the outcomes that really matter to patients and their families. So massive congratulations to everybody. The second thing that I wanted to say, and Marnie's already said this, is do use and share the document. So, I mean, I think it is really important that, you know, we do inform patients and their families about what they can expect. We know that having a stroke it's terrifying. It's overwhelming. People just do not know what to expect. So actually giving patients this kind of information is a really important way of helping them to feel more in control, knowing what the next steps are with their treatment and care plan. And also they can ask informed questions. And the reality is that patient power will help to drive up standards. I know it might make some of you sometimes feel a bit uncomfortable, but actually I think we need a bit more of that patient power in our quality improvement processes. And then the other thing that I would say to healthcare professionals, and I know a lot of you do this, but I picked up a really nice example earlier this week from the Addenbrooke's team, the therapy team at Addenbrooke's, who've used the data about increased physiotherapy staffing levels, reducing length of stay and improving functional outcomes. And they've used that evidence base to get the trust to invest in their whole therapy workforce. So it's just a fantastic example of how you can kind of use this guideline and the evidence within it to support your local advocacy efforts, to strengthen your local business cases, to get your local commissioners and funders to invest in what we know are very significant workforce gaps. So I really would encourage you to do that. And I think the combination of your local data with this national evidence can be a really powerful tool for change. And then the final thing I just wanted to say is at the Stroke Association, we're absolutely determined to try and make stroke the priority it needs to be in all 4 countries of the UK. So we will absolutely do our best to promote the message that, you know, we've got really strong evidence for interventions in stroke. We know what works in terms of making stroke preventable, treatable, and recoverable for tens of thousands more stroke survivors, and we will continue to bang the drum that it's really exciting. We know what works in stroke, so get behind investing in stroke services, because actually you invest in stroke, you improve outcomes for patients, but you also address a lot of the system pressures that we know the system is struggling with, not least of which the burden on social care. So we will play our part. We will continue to influence for proven interventions that can be adopted at scale. You probably all know that we launched our Saving Brains campaign for universal access to thrombectomy and to reduce, frankly, the unacceptable variations in access to thrombectomy. We will continue to campaign for that. We're also going to be strengthening our messages around the need for emotional and psychological support for stroke survivors, 6-month reviews, thank you to the gentleman who's already raised that, and the need for universal access to a stroke key worker for everybody, because we know a stroke key worker can make a real difference in helping stroke survivors access all the available support that's out there in the community. And we're also committed to improving the quality and personalisation of our own services. You know, we need to hold the mirror up to ourselves, and we're committed to doing that to try and make sure that our own support offerings really match up to the recommendations in the guideline, and that we can be really confident that every interaction we have with every stroke survivor is best quality and really personalised around their needs. So yeah, we will try our best. We'll work tirelessly to advocate for stroke and for the outcomes that matter to stroke survivors and their families. And I think we all owe it to them to be ambitious, don't we? Because we know that stroke is preventable, treatable, and recoverable for tens of thousands of more people than it is today. So, thank you.
Thank you, Juliet. I hope we've been able to offer you some respite from the rarefied atmosphere of the Department of Health. So it just remains for me really to thank you all for your attention, both online and in the room. It's not over yet. There are drinks and canapes shortly available. I suspect that there will be members of the team happy to guide you there, but it'll be in the atrium upstairs, won't it? Back up the stairs that you came down on your way here. And there'll be a drinks reception available for all of you. Just to say that the editors are now on tour. So we are open to opportunities to promote and disseminate and support your organisations, your professional organisation or your local regional groups in disseminating the guideline, because no guideline is effective unless it's implemented. So we're open on the stroke guideline email that's on the website to invitations to promote and disseminate the guideline. We will keep banging on about it, and we hope very much that you all will too, because the ultimate aim of improving life for our patients with stroke is one that we all share. So that's it. Thank you very much indeed for your attention. If you've got colleagues who would like to see the content, then in about a week's time it'll be available on the resources button on the Guideline website, and so we look forward to many more of your visits to see us presenting the new guideline. Thank you very much.